All right, medical officers, welcome. Let's dive right into your survival guide for the KTP Reno rotation. We're going to tackle some of the most common and, frankly, most stressful electrolyte and acid-base emergencies you'll face on call. The goal here is simple, to get you feeling confident when that pager goes off.
Okay, picture this. It's 3 a.m. The nurse pages you. Doctor, your patient's sodium is 115 and they're getting really confused. I guarantee you're going to get this call. This is a real medical emergency, and how you respond in the next few minutes is absolutely critical. So let's break down how to handle this. Hyponatremia is, by far, the most common electrolyte problem we see in the hospital. Getting this right is a fundamental skill, and it all starts with a clear, logical plan.
Your investigation is basically a three-step mission. First, you check the serum osmolality to make sure it's a true hypoosmolar state. Next, check the urine osmolality. This tells you if the body's water-retaining hormone ADH is working when it shouldn't be. And finally, you check the urine sodium. Just a little heads up, context really matters here, because most of the time, the urine sodium is actually high.
Now, if you only remember one single number from this entire section, please make it this one. For a patient with chronic hyponatremia, your maximum correction limit is 6 to 8 millimoles per liter in a 24-hour period. You absolutely cannot go faster than this.
And here's exactly why that limit is non-negotiable. See, the brain is smart. It adapts to that low sodium environment. If you raise the sodium level too quickly, you create this massive osmotic shift that literally pulls water out of the brain cells. The result? ODS, or osmotic demyelinating syndrome, and that can be catastrophic. It's no joke.
Okay, next up, a situation that should get your heart racing. The lab calls with a critical value. Your patient's potassium is 7.0. This, my friends, is a true ECG emergency that demands you act and act fast. But hold on. Before you start pushing meds, take a breath and ask yourself, is this for real? Pseudohyperkalemia is a thing. It's a falsely high reading, maybe because the blood sample hemolyzed, the red cells burst, or the patient was clenching their fist too hard during the draw. If the clinical picture doesn't quite fit, always repeat the sample. You don't want to treat a lab error. So you've confirmed it's real hyperkalemia and you see those classic peaked T waves on the ECG. Your response follows this life-saving three-step mantra. Just burn it into your brain. Stabilize, shift, and remove. Now listen up, because this is super important. Your very first move is not to lower the potassium. I know, it sounds counterintuitive, right? But your number one job is to protect the heart. IV calcium gluconate stabilizes the cardiac membrane, basically acting like a shield against deadly arrhythmias. This is priority one. Okay, heart protected. Now you need to buy yourself some time. An insulin and dextrose cocktail is your go-to. It works by driving that extra potassium from the blood back into the cells. Just remember, this is a temporary fix. It'll work for about 2 to 3 hours, but it's a crucial bridge to the final step. And finally, you've got to get that potassium out of the body for good. This is their remove phase. What you use depends on the patient. It could be diuretics like furosemide, maybe some potassium-binding resins, or if things are really bad, they're going to need urgent dialysis. All right, let's quickly flip the script to low potassium, or hypokalemia. You've probably heard this rule of thumb. For every 1 millimole drop in serum potassium, the body is down about 200 millimoles total. But here's the pro tip, the really crucial part. That rule only works for true losses, like from the kidneys or the gut. It does not apply when the potassium has just shifted into the cells, like you might see in refeeding syndrome. Big difference. Okay, another classic on-call scenario. A nurse pages you that your patient is complaining about tingling around their mouth, maybe some muscle twitching in their hands. Your brain should immediately be screaming, check the calcium. This is classic hypocalcemia.
The list of causes here is pretty broad. Yeah, you're thinking of the obvious stuff like advanced kidney disease or someone who just had their parathyroid out. But don't forget the other culprits. It can be caused by severe sepsis, low magnesium levels, certain drugs, or even after a massive blood transfusion because of the citrate in the blood bags. So, when do you give IV calcium? The answer is really simple. You treat urgently if the patient has those classic symptoms we just talked about, or if the lab calls you with a critically low ionized calcium level. It's a straightforward trigger. Last but definitely not least, let's quickly touch on acid base. You get a blood gas report back, and it's showing a metabolic acidosis. What's your first step? Where do you even start with this? Your first move, every single time,
is to calculate the anion gap. This simple little formula, just sodium minus chloride and bicarb, is the key that unlocks the entire differential diagnosis. It tells you if you're dealing with an extra acid floating around or if the body has just lost bicarbonate.
And if you do find a high anion gap metabolic acidosis, what we call a HAGMA, the mnemonic you need to know is GOLDMARK. This thing is brilliant. It covers everything from glycols and lactate to renal failure and ketoacidosis. This is your mental checklist. Whew, okay, that was a pretty rapid tour through some high-stakes situations. So let's pause and lock in the absolute must-know take-home messages from our little survival guide here.
All right, here are your survival points. 1. Hyponatremia. Slow and steady wins the race. No more than 6 to 8 in 24 hours. 2. Urgent hyperkalemia. It's that 3-step dance. Stabilize, shift, remove. 3. The hypokalemia deficit rule. Remember, it's for true losses only. 4. Symptomatic hypocalcemia gets IV calcium, period. And 5. For any metabolic acidosis, your first step is always the anion gap. Get these down and you'll be ready.
So as we wrap up, I'll just leave you with this question to think about. Which one of these emergencies are you going to be looking out for on your next call? Thinking about it now keeps these principles fresh in your mind for when that pager inevitably goes off.
You've got this. Thanks for listening and good luck on your posting.